This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Diabetes is not just a strategy that lives in your endocrinology service line. It's a strategy that needs to be system-wide. We know that this disease state interplays with multiple other service lines, whether that be primary care or cardiology or nephrology. There's going to be a greater demand because we see incidence and prevalence rising in both type 1, type 2, pediatrics, and adults. That's the common thread across the board.
Welcome to Sg2 Perspectives. I'm your host, Jayme Zage. I want to cover a clinical topic today from a strategic lens. Diabetes is one of the most prevalent chronic diseases and is a major driver of healthcare services. Strategically, we need to plan for the fact that diabetes is a collection of divergent conditions and patient populations, and we need divergent programs. There are two types of diabetes, and they are very different in terms of the care that they need to manage them. And we also have two major populations, pediatrics and adults, who experience the disease in very different ways. Moving forward as strategists, we must think more carefully and segment these patients and how we deliver care in order to have the most effective care outcomes. To help us unpack this, I've asked my strategically thinking colleagues, Fitt and Rhae Gamber, to join us. Emily is our lead for adult medicine and Rhae is our lead for pediatrics. So welcome, Emily and Rhae. Let's just talk a little bit about the basics. Tell us about the differences between adult and pediatric diabetes.
When we think about diabetes, the primary provider is one of the main distinctions when we think about type 1 versus type 2 diabetes. For type 1 diabetes in adults, the primary provider can often be an endocrinologist. Some type 1 diabetics will see the primary care provider, but most are treated by the endocrinologist. In type 2 diabetes, more often that patients are managed by the primary care provider. Normally, a new patient will start by seeing an endocrinologist, but then transition to a primary care provider for ongoing management. We need to think about expanding those multidisciplinary models for both type 1 and type 2 patients, because what the similarity is in adults for both of these types is these patients are going to need other services like cardiology or nephrology or behavioral health. As a system, we need to think about how do we coordinate those.
Well said, Emily. And I can dive in on the pediatric side. When we talk about diabetes, we talk about it like it's one big thing. Emily, what you've illustrated is on the adult side, we tend to skew towards our type 2 conversation. That is very different on the pediatric side. When we're talking about pediatric diabetes, yes, both conditions are relevant, but type 1 is what makes up the bulk of our inpatient utilization and the bulk of outpatient utilization as well. Now, type 2 has gotten a lot of hype because there has been tremendous rising prevalence in pediatric type 2 diabetes that coincides with the pediatric obesity epidemic. But we've also seen rising prevalence of type 1 diabetes sort of in line with what we've seen in autoimmune disorders more broadly. Utilization here looks quite different in pediatrics than adults. For type 1 inpatient discharges, this is often not just an advanced state of the disease of diabetic ketoacidosis and a really exacerbated time because of poor control of the disease. But for many pediatric patients, it's their initial diagnosis. They don't even know that they have diabetes or that their blood sugar has been out of control. They're just really sick and they go to the emergency department and they get admitted. This is a really crucial time for pediatric patients and for health systems, children's hospitals to be setting that child up for success in diabetes management for the rest of their life. It's not just about stabilizing the patient. It's also about intensive education, potentially lifestyle modification, nutrition, and behavioral health screening. Emily, you mentioned the multidisciplinary care models. Children's lives are forever changed when they're diagnosed with type 1 diabetes. They have to care about things that other kids their age are not caring about, like how much they're eating and whether or not they have carbs and sugar in them. That consistent behavioral health screening is really crucial in a pediatric time frame for type 1 diabetes in particular. Type 2 diabetes, less of a, from a volume standpoint, relevant in pediatrics, but a growing and emerging disease. A point that's different here between adult and peds primary care being a key provider for adult type 2 diabetics. On the ped side, we still see most type 2s really being managed by an endocrinologist like type 1 because there is a need to more closely manage that patient. And there's likely a greater need for cardiology, GI as well. These are often patients that are going to be eligible for the use of GLP-1s as well as overall obesity management.
So that is a great introduction to the differences, not only in type 1 versus type 2 diabetes, but also adult versus pediatrics. One of the things that I noticed in some of the most recent materials you've been putting out through Sg2 is that inpatient admissions are declining for certain types of patients, definitely for pediatrics, and then again for type 1 diabetes in adults. So tell me a little bit more about what's driving that. How are the care paths different that might be pushing us in that direction? Is there something we can learn and apply to adult type 2 diabetes?
Let's start with pediatric type 1 diabetes. Here is where we have our biggest decline, 14% projected decline over the next 10 years. And that is driven by a couple of things. First and foremost, the care models and the technologies that we are deploying that enable better control of disease and reduce that need for an exacerbated event and a visit to the emergency room. Better outpatient management, use of the continuous glucose monitor that warns us of highs and lows before they get even higher or even lower. A lot of these discharges are initial diagnosis, so that won't apply to that group. But there is another trend that is impacting the initial diagnosis group that will drive decline. And that's exciting new biologic that has been approved that is super exciting in the type 1 diabetes world. It's called Tzield. And the idea is that it can delay onset of stage 3 type 1 diabetes, meaning that point in your diabetes journey where you actually need regular insulin. So it'll actually delay the onset of that. In clinical trials, it's found for up to 2 years. So it could just be shifting some of that pediatric utilization into the adult utilization bucket where Emily has to deal with it. But it's great to know that at least some adolescents can delay the onset of stage 3 type 1 diabetes. Now, of course, this means we have to be screening to understand which children are eligible to receive Tzield and delay that onset. This was where primary care comes in. There's very simple screening blood work done for type 1 diabetes. So we need to be identifying patients who are at risk, typically those that have family history, and getting them access to those screening tools. And the more we screen, that helps drive that negative decline because hopefully, even if those children aren't accessing Tzield, at least they may be more aware of their condition and may not be at quite that sick state when they end up getting their initial diagnosis. So that will drive additional inpatient decline. On the type 2 side for pediatric type 2 diabetes, here we have a 5% decline projected over the 10-year time frame. These are care models that support chronic disease management. We should note this is very low volume. There's not many type 2 discharges in pediatrics. The other driver of decline is uptake of GLP-1 agonists. Yes, children are accessing GLP-1 agonists for type 2 diabetes as well as obesity, and type 2 being where children have historically already been accessing this before the recent revolution of GLP-1s. Those are some of the drivers of decline in the pediatric forecast.
On the adult side, we are projecting type 1 diabetes to decline 3% over the 10-year time frame. And we're cascading some of those impacts of coordinated care, use of continuous glucose monitors. Even those therapies like Tzield are going to result in declines in the inpatient setting, especially when kids are found or screened early and we know that we could delay the onset. That might stop an adult from crashing into the ED or crashing into the inpatient setting. We can slowly ease them into treatment with those therapies. On the type 2 side, we're projecting about an 8% increase. And what's very different here is that the initial diagnosis, that inpatient visit is often where they're diagnosed. For type 2 diabetes, the onset isn't necessarily as stark where you're going to the ED or you're going to the inpatient and you're getting diagnosed with something. It's often you're easing into something or you're finding out at your primary care appointment that you have type 2 diabetes. What are these volumes for type 2 diabetes in the inpatient setting? It's folks that have trouble controlling their chronic condition. It could be adults that have social determinants of health barriers, folks that have a hard time adhering to treatment plans or their medications. There could be be a number of reasons why somebody might end up inpatient for type 2 diabetes. We're also thinking about the intersectionality between type 2 diabetes and cardiovascular conditions, or type 2 diabetes and wound conditions that are driving some of this demand inpatient. We do have the last 4 to 5 years of the forecast plateauing. That is due to innovations of GLP-1s and SGLT2 inhibitors. And these medications were piloted and started in the diabetic community. We're now starting to see more folks with type 2 diabetes on these medications. Right now, it's about 1 in 4 adults with type 2 diabetes are on a GLP-1, and we're seeing that number continue to climb farther, which can help prevent ED utilization and inpatient utilization. But it's going to take time to see that on a national level.
That's great. It's really interesting. You both have mentioned some innovations that we've been talking about, continuous glucose monitoring, the new medications to help prevent the progression of type 1, the GLP-1s we've been talking about for a while now, pretty intensely. Are there other innovations that you all are watching? And they could be clinical, they could be care delivery, redesign type innovations. What do you think is going to change that trajectory that we haven't already talked about?
Rhae and I have both mentioned a lot of those clinical things, continuous glucose monitors, pharmaceuticals. One thing we haven't touched on is now the innovation that we're starting to see in care redesign. A big thing, especially for type 2 diabetes in the adult side, is utilizing risk stratification and proactive disease management. We're looking at utilizing EMR data or community health needs assessment data to proactively screen folks in order to get them tested so we can connect them with care at an earlier point in their disease state. We're also seeing more systems as they enter the AI, the virtual, the digital space, specifically focusing on diabetes management for asynchronous visits and virtual visits and remote patient monitoring, especially for those patients that have a pretty good control of their condition and just need monitoring of their disease to make sure that we don't see an exacerbation of symptoms. We're also seeing the embedding of ancillary support like behavioral health specialists or pharmacists to help appropriately measure medication or manage different medications for adults on those new innovations like GLP-1s. And then we're seeing more partnerships within health systems and device companies, thinking like continuous glucose monitors that assist in overall data collection so we can better meet the needs at a population level, but also all the way down to an individual level.
That was very well stated. All of those things apply to pediatrics. I would just mention automated insulin delivery pumps. We used to call this artificial pancreas and made it sound a lot more technologically advanced. But where we've got our CGM and our insulin pump talking to each other and delivering insulin without the touch of a button or without that human interaction. That's a really big deal for diabetes control. We've been dreaming of that for a long time, and it is here. Children are on that model. It certainly requires close monitoring. We don't want mistakes to happen in the automation, but the fact that that is happening, it helps parents sleep at night. The high acuity treatment landscape, I'll call it, or even more surgical side. We're talking a lot about bariatric surgery lately. That's not necessarily new and innovative, but that will drive shifts in utilization in type 2 diabetes, both in the adult and pediatric space, as we see bariatric surgery growing a lot in pediatrics. And then far out, we talk about potential for islet transplantation in pediatrics as well, which could cure type 1 diabetes.
You're watching it, but we're not quite ready to predict how much of an impact yet. As we think about the newest innovations, we think about the fact that this is not a single population, not a single disease. What advice would you give to healthcare leaders and in particular to strategic planners who want to support those leaders about how they can move the needle on their diabetes care programs?
The big thing here is that diabetes is not just a strategy that lives in your endocrinology service line. It's a strategy that needs to be system-wide. We know that this disease state interplays with multiple other service lines, whether that be primary care or cardiology or nephrology. There's going to be a greater demand because we see incidence and prevalence rising in both type 1, type 2, pediatrics, and adults. That's the common thread across the board. It's growing. There's going to be greater demand for things like screening efforts, for monitoring of folks that have been diagnosed, for complications management. if health systems are looking to up their diabetes game, preparing for that increased demand in multiple different threads. We also know that this creates opportunity in the tech and digital space. This is a great condition or a great area to pilot something like a remote monitoring chronic disease program. And it's a great one because of all the discharges that we see, especially for type 2 diabetes patients on the inpatient side, to reduce that utilization. This community is not necessarily a monolith. There are going to be differences in pediatrics versus adults. There are differences in type 1 and type 2 diabetes. There are differences between a patient that can easily control their symptoms and a patient that may have a harder time controlling their symptoms. When we think about system-wide level strategy, we need to dig into the nuances of those different categories.
This is a hospital-wide issue or concern. This is not just something that endocrinology needs to be worried about. Emily did a great analysis using the Vizient clinical database that illustrates how both length of stay and readmission is higher across all service lines when those patients have diabetes comorbidities. And so it really sets the stage. If you're needing to go to your hospital leadership and explain why this is an important issue, I mean, this is a great analysis to bring to them because it's impacting your quality outcomes at the highest level, not just within our diabetes services. That's point one, which leads nicely into point two, which is measure outcomes and make sure you're defining based off of these unique patient populations. Don't just talk about diabetes anymore. When you're talking about diabetes, let's talk about type 1 versus type 2. And if you're delivering pediatric care, let's specify those differences as well. That's going to be really important. From a strategy perspective, Emily hinted at this earlier, type 2 is deeply tied to social determinants of health and your health equity work. The more that we can call out those differences, we see on the pediatric side, type 2 diabetes utilization is almost 80% Medicaid, which is very different from type 1 and very different from other services across the system. Tying this work to our community needs and our social determinants of health work as well. And then lastly, the point around clinical research. If you're wanting to elevate your program, remembering that there's still so much we don't know and so much we can learn about the care delivery of diabetes, participating in the vast clinical research world would be another way to up the ante on your diabetes program.
That's a great insight. And I really appreciate, Rhae, you bringing up the social determinants piece and the vulnerable patient populations. Some work that we've done in collaboration, leveraging the Vizient Vulnerability Index, has really shown that some of those individuals who are economically challenged maybe don't have access to healthy foods or have transportation issues, may not always get the best diabetes care or be challenged to manage their disease as effectively as someone who's a little bit more well off. It's not even about what age they are or what type of diabetes they have, but it's personalizing based on what do they need to do differently to better manage their disease. And that is a part where I think the behavioral health component comes in significantly to help those individuals. Thank you both for bringing this forward and talking about this with our Sg2 Perspective audience. And to our listeners, thank you as always for joining us.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.